Hello, my name is Katja Weisel, and I'm head of the myeloma program at the University Medical Center Hamburg-Eppendorf in Hamburg in Germany. And I'm going to present some of the key data from ASH 2024 on BCMA-directed therapies and multiple myeloma. And then I will be joined by my colleagues, Dr. Nisha Joseph and Professor Hájek, to discuss the clinical implications. First, I will focus on some of the data from this Congress relating to approved indications for BCMA-targeting agents. So we are starting with the abstract 473A. This is a long-term update of the efficacy and safety of less frequent dosing of elranatamab, one of the approved anti-BCMA bispecific antibodies in patients with relapse and refractory myeloma. And this abstract reports on a bit more than 120 BCMA-naive refractory patients, triple-class exposed, and in the vast majority also refractory with a median prior lines of therapy of 5. And here you see the treatment schedule. The sub-Q elranatamab was used after step-up priming, followed by weekly doses, but patients with equal or more than 6 cycles of the weekly dosing achieving a response of at least a partial remission for at least 2 months. They were then transitioned to a weekly dosing, and after that, in the same manner, in the potential of dosing every 4 weeks. And with that a schedule, you see here that of the 123 patients, about half switched to the dosing every 2 weeks, and again about half switched to the dosing every 4 weeks. And of those switching to the every 4-week schedule, more than 90% maintained the response for more than half a year post-switch, and nearly 90% maintained a complete response or better, and only 4% had disease progression. So on those patients, the median PFS was 17.2 months, and the median overall survival close to 25 months with a high MRD rate. When we look on the safety before the switch of the monthly dosing and after the switch, it tends to be a bit less toxic regarding infection rate. So coming track 934, this is an abstract published by the U.S. Multiple Myeloma Immunotherapy Consortium, a very important group reporting on real-world data, especially in the times of the novel generation immunotherapeutics. And here we look on the outcomes of elderly patients with relapse and refractory myeloma disease treated with teclistamab. And these patients, and this is a large patient group, overall consisting of about close to 400 patients, was analyzed in regards of age. And we look here on 83 patients receiving teclistamab and being 75 years or older, and who are compared to younger patients, which were more than 300. And from the baseline characteristics, we see here that the elderly patient population for sure had less prior autologous stem cell transplantation. Also, when starting teclistamab, less extramedullary disease and a bit less prior BCMA-directed therapy, but overall a comparable patient population with a median prior lines of therapy of 6. So looking on the efficacy, we see that patients who are 75 years or older had comparable efficacy regarding overall response rate and equal or more than VGPR rate. And the median PFS and median overall survival is also in in a decent range after a median follow-up of 9.9 a month, indicating a high efficacy of teclistamab also in elderly and old patients. Looking on the safety, and this was an important point in this analysis, we see that in regards of CRS and ICANS, there was no markedly enhancement of toxicity in the elderly patient population. Comparable use of tocilizumab and steroids was documented. And then we come to abstract 897, and this is again from the same consortium, the data on teclistamab in patients with prior exposure to BCMA-directed treatment, a very important question in the real world setting. And this was a population of close to 200 patients, and the majority had received one BCMA-directed therapy, but there were also more than 20% who had 2 or more BCMA-directed therapies before, and nearly half of the patients were penta-refractory in addition. You see here that most of the patients analyzed had a CAR T-cell therapy before, followed by antibody-drug conjugate treatment. You see the response rates on teclistamab after median follow-up of close to 10 months, with an overall response rate a bit lower than in patients with no prior BCMA-directed therapy, however comparable, still comparable, a bit lower overall response rate, VGPR rate, nearly same rate of complete remission. And here, regarding the overall survival, we see that the 6-month and 12-month overall survival rates were comparable in both populations. The overall response rate to teclistamab was more than 50% in patients with a prior CAR T-cell therapy and close to 50% with the antibody-drug conjugate pre-treatment. Very few patients have had an anti-BCMA bispecific antibody before, and here we see only a low overall response rate. PFS was 5.9 months in those patients with one BCMA-directed therapy before receiving teclistamab, and had no difference when comparing those having had an antibody-drug conjugate or CAR T-cell treatment. But what the colleagues could figure out very clearly, the PFS was dependent on the interval between the BCMA-directed therapy and the use of teclistamab, and overall those patients who had an interval of more than 8.7, so close to 9 months, they had a much better outcome on the teclistamab treatment. In regards of toxicity, there was no sign that this enhances toxicity if an anti-BCMA agent was used before. And then we have the abstract 936 on comparative safety and efficacy analysis of cilta-cel and ide-cel, the both approved anti-BCMA CAR T-cell treatments in relapsed and refractory myeloma. And as there was no head-to-head comparison in a phase 3 trial, and here we look again on the real-world US data, however very important, and a large patient number of 350 ide-cel patients and 236 cilta-cel patients. With a comparable patient profile, I can say a median age of about 65 years, and patients had a comparable characteristics in regards of extramedullary disease, high risk cytogenetics, and penta-refractoriness. When we look first on the toxicities, we see a bit more a CRS of higher grade, and especially a clear sign for a significantly more delayed neurotoxicity when cilta-cel was used. However, regarding the non-relapse mortality, despite it was a bit high in cilta-cel, this was not statistically significant. Looking on the efficacy, we see a higher efficacy for cilta-cel in regards of response, in regards of CR rates, and also in the intent to treat and the infused population. And this is also translated in a higher survival rate when cilta-cel is used. So here it was shown in the direct comparison that cilta-cel is more effective in regards of response and survival. However, limitation is that this is a retrospective study design. Now coming to abstract 1032. This is an analysis of MRD-negative patients in the pivotal CARTITUDE-4 trial, comparing cilta-cel to standard of care in patients with first to third relapse. We look on patients receiving an MRD-negative remission, and this was much higher in the cilta-cel treatment arm compared to standard of care, which was Dara-Pomdex or a PVD, and even more importantly, you see that the sustained MRD-negative CR lasting more than 1 year is markedly and significantly higher when cilta-cel was used. However, even more striking, I think, are the survival rates on the MRD-negative population. We see that those patients who had a sustained MRD negativity, the PFS and overall survival rates are more than 90% after 30 months. And even in patients, and this is higher than in those patients being MRD positive. I would now like to welcome my co-faculty, Dr. Nisha Joseph and Professor Hájek, to discuss the clinical implications of these data. And Nisha, may I start probably with you? Looking on the magnetism 3 data when the application of elranatamab was stretched, what effect might we anticipate on the patient experience and also quality of life with the potential for less frequent dosing?
Yeah, absolutely. I think this is really important data, and we've seen similar data with the other bispecifics, with teclistamab and talquetamab, looking at really what is that optimal dosing schedule. And we've actually already started implementing kind of the less is more, and really following more of a Dara-based dosing schedule, trying to get to that monthly dosing really as soon as possible, both for safety and patient experience, but also for efficacy, and trying not to really overwhelm those T cells. And we're seeing that in preclinical data, support for that as well. And so I think, as you mentioned, we're seeing more infection and cytopenias early. I'm a little surprised that we didn't see less cytopenias when they switched to monthly. I wonder if that just wasn't enough follow-up, because certainly clinically, when we back off on the dosing and we're giving patients monthly IVIG routinely, which was not always done in some of these trials, we're seeing a lot less infections. We're seeing recovery of counts. And certainly for the patients who've been on, many of these patients have been treated for a long period of time, being able to back off on that, also on the dosing, they're only coming once a month. It really helps with quality of life. So we've really tried to back off, whether that's response directed or not. That tends to be the case. We try to back off on the dose, and I think that really has a lot of benefit for the patients in terms of side effects as well as just their experience.
Yeah, thank you. And I would hand over to you, Roman, looking a bit more on the majority of the myeloma patients who are elderly and old and affected by myeloma disease. And with the emerging novel generation in immunotherapeutics, I think that were very important data from the US consortium on teclistamab in different patient populations. And what's your view on the data, especially for elderly patients, and also those patients, if I can add that, who were pre-treated with any BCMA targeting agents, and how would you implement those data in your daily clinical practice?
If I can start now, for elderly, I think we still have to learn, but to me, there is no age limit. This is some biological limit. We definitely need more and more use the strategy which was discussed. So to use low dose of any bispecific antibody, switch or change the schedule as soon as possible to monthly dosing. And for elderly, it will be really beneficial for them. And for pretreated patients, I have to smile a little bit, because we know it is myeloma. It's, I think, general for all cancer. If we use similar drug for second run, it's always not so effective as we need. So to me, I just want to emphasize, if we see the progression-free survival at that setting 5 months, it's not effective. It's not cost-effective. It's the similar analysis as we saw for standard treatment for patients triple refractory, which was progression-free survival between 2 up to maybe 4 months. Whatever we used, it was not effective. And similar, when we use the bispecific, especially after bispecific with same target, it can't work properly.
I completely agree. And I think really the point is time between therapies. So when you look at folks who have BCMA CAR T followed by BiTE versus BiTE to BiTE or BiTE to CAR T cell therapy, I think if you have to pick one of those, as Dr. Hájek was saying, in CAR T to bispecific, if you're going to use the same target, it makes a lot more sense, because on average, you're going to have a longer treatment-free period in between. So on average, you're getting 1 to 3 years, depending on what product you're using. And so that sequence certainly makes more sense. I think I certainly still use BCMA again in patients. I think often we don't have a choice once you get into that heavily refractory space. If we are able to class switch, I think that obviously would be ideal if we can go to 5D or something else. But I think what I take from these is really about the time in between therapy. So if you can use something else before going back to BCMA, or if you're able to go to a CAR T cell therapy, if the patient's disease allows you to do that first, that certainly would be optimal, prior to a BiTE versus the other way around. And certainly BiTE to BiTE is very challenging, although again, sometimes that's the choice we have.
And sticking stop around on CAR T, we have 2 approved CAR T cells with different availability over the world. So we saw again a very convincing data out of CARTITUDE-4 at this last ASH meetings. We saw the first retrospective head-to-head comparison. So probably you can both share your individual thought. How early do you now offer your patient the CAR T cell treatment? Which CAR T cell do you use in your clinical practice? Do you think every LAN refractory patient at first relapse, if available, should have cilta-cel? Probably you both give a short answer of your thoughts.
Sure. I can start. I think for me, I think that the data was very impressive. The early approval for me is about choice. And instead of trying to somehow get to the fourth line, we're able to use, we use more cilta-cel really in the US than ide-cel. We can use it earlier. I think for that standard risk patient who's having a good response on len, has indolent disease, I'm a little more hesitant to go to cilta-cel at first relapse. I think some of those neurotoxicities are concerning, but certainly in the second line or third line space, I think we're using a lot more. And then the caveat is using cilta-cel earlier for high-risk patients who are not responding the way either high risk by cytogenetics or biologic high risk, and they're relapsing early post-transplant. We're using cilta-cel a lot earlier for those folks.
Yeah, and my comment would be short. It's no chance to compare face-to-face any of this therapy in late relapse. We missed opportunity to compare such CAR-T therapy in early relapse. So I really wonder if and it would be definitely big challenge to compare any combination with one product versus second product. It's very challenging because, the progression-free survival in newly diagnosed setting would be 8 years, 9 years. And what we know what happened during this period of time. So it would be very difficult to compare these drugs face-to-face generally. So, okay, we have some retrospective analysis. This is first one. Actually, my feeling was that cilta-cel is slightly better than ide-cells, and it was basically shown despite its retrospective analysis. I agree with this.
Thank you both for this inspiring discussion. In this section, I will focus on some of the data from this Congress relating to new approaches to the use of existing BCMA-targeting agents. We start with abstract 772. This is a phase 3 trial comparing belantamab mafodotin in combination with bortezomib, dexamethasone, or BVD compared to daratumumab, bortezomib, dexamethasone, or DVD in relapsed and refractory myeloma from first relapse on. And this is the DREAM7 trial and the overall survival analysis and updated efficacy outcome. So in this large phase 3 trial, both treatment arms, DVD and DVD, were compared in a 1-to-1 comparison with the primary endpoint of PFS, and overall survival was the key secondary endpoint. Patients were well balanced between the two treatment arms. Close to 500 patients were included, and they must not been refractory to bortezomib or daratumumab, and about half of the patients had prior lenalidomide treatment. And look, when we are looking now on the 24-month overall survival rate and 36-month OS rate, we see a clear and statistically significant benefit in favor of the belantamab mafodotin combination treatment compared to DVD. In the updated analysis also, it was confirmed that the efficacy of the DVD regimen was higher than of the DVD regimen, as it was the duration of response and the MRD negativity. This benefit of the belantamab mafodotin bortezomib dex combination was extended beyond the primary endpoint PFS towards overall survival, duration of response, and MRD negativity. And the authors concluded that DVD will be one of the standard of care regimens when approved for patients with relapse and refractory disease. Where we look on always when we look on belantamab mafodotin are the ocular toxicities, and this is a busy slide, but what we can say is that a majority of patients had an ocular toxicity in the belantamab arm, but that this was reversible in nearly all patients, and that this toxicity now reported did not differ from the primary analysis. So now we are coming to again belantamab mafodotin combination in the DREAM-9 trial, abstract 497. And now we move into newly diagnosed multiple myeloma in transplant non-eligible patients. And this is a phase 1 study combining belantamab with VRd as one of the standard of care treatments for this population. A bit more than 100 patients were included in overall 8 cohorts where the belantamab dose and the dose application schedule differed, and belantamab dose applications were also stretched. The major focus is on patient safety in this phase 1 study, and especially again in the ocular event. And here you see that in the cohorts 1 to 3, with a dose of belantamab every 3 weeks in 2 cohorts, or every 6 weeks with a higher dose, that a bit more than half experienced equal or more than grade 3 ocular event, and that nearly all patients experienced those interruptions or delays. However, that overall we have a decrease of the ocular events when the interval of belantamab mafodotin was stretched. The overall response rates and CR rates were very promising in the study, and it depended on the median follow-up and the cohorts, but up to 100% over response rate, and between 30 and over 90% of complete remissions were documented. We are now going to a very interesting trial again in newly diagnosed myeloma patients, abstract 493. And this is a phase 2 study of the 2 German groups introducing teclistamab in frontline treatment of transplant-eligible patients. So for a small cohort of close to 50 patients receiving teclistamab in combination with daratumumab and len, and partially also bortezomib in a quintuplet situation or a quadruplet setting. So these are young patients with a very good performance status, and we look on their very early data, and we see that there was a very high response rate early on in the induction treatment in this patient. However, I think the most important point was here that nearly all patients achieved an MRD negative remission. Regarding toxicity, there was a reported significant and marked hematologic toxicity and an infection rate of higher grade infection of 35%. There was no safety issue regarding CRS and ICANS in an unexpected manner. Regarding infection, the patients were on IVIG substitution. And we are coming to teclistamab in the maintenance treatment, abstract 494. Teclistamab alone or in combination with lenalidomide in newly diagnosed patients as maintenance therapy following autologous stem cell transplant. This is a trial of the European Myeloma Network, and we look here on close to 100 patients, also young patients, a median age below 60 years, and these were patients who had responded to the initial treatment and the high-dose Melphalan. First glimpse was on the toxicity, and we see that patients had a significant hematologic toxicity when teclistamab was used in maintenance treatment, especially in the first cycle in regards of neutropenia. And when we look on the infections, we see that the grade 3-4 infections were markedly enhanced with, again, in the first maintenance cycle, close to 40%. However, patients are now in this trial strictly on IVIG substitution. In regards of efficacy, I think this is very promising. We see here that nearly all patients turn to equal or more than a CR, and all those patients being evaluated were then MRD negative. And now back to the relapse setting, abstract 495, teclistamab in combination with daratumumab and pomalidomide, and data of the TRIM2 and MajesTIC-2 trials. Very few patients in this combination treatment, 27 patients receiving this triple combination. And we see here that there is a significant toxicity reported, significant hematotoxicity, also infections. And we saw in this 27 patients, 7 deaths, and 6 of those with an infection background. However, there was an intensified infection prophylaxis plan then implemented. Regarding efficacy, very promising data, high CR rate, over half of the patients, and these were pre-treated patients. So there's no doubt DP has a promising efficacy and a relapse and refractory myeloma, but patients have to be definitely on a supportive care schedule. I would now like to welcome my co-faculty, Dr. Nisha Joseph and Professor Roman Hájek, to discuss the clinical implications of these data. I have a question to you both. So we looked on the large DREAM7 trial introducing a belantamab mafodotin triplet with very interesting and data. And what do you think about, will we get the drug back in combination treatment, and how would you use it in your daily clinical practice? How is your view on this data?
Definitely belantamab is back. I think after a very slightly painful learning curve, we can see excellent data from DREAM7, but also from DREAM8, I remind you. And to me, this is typical situation in first relapse. Then we now have another quite really strong regimen. We're not discussing bispecific CAR-T, but we have now isatuximab, carfilzomib, dexamethasone, IMiD-free regimen, and second one, this one, belantamab, bortezomib, dexamethasone. There are 2 very strong regimens which can be used in first relapse. If in newly diagnosed setting, we will use lenalidomide and daratumumab, and patients will progress on these drugs.
I agree with Dr. Hájek. I think absolutely belantamab is coming back. I think the data is very impressive. I think we're going to see more belantamab, earlier. I think the challenge certainly in our practice will be, I think this is an opportunity for the community to deliver BCMA therapy, more so obviously the bispecifics and CAR T-cell therapy that they have to refer to us. So I think an ongoing challenge with this drug is making sure that we have clear protocols and make this accessible for the community in terms of how to manage ocular toxicity. And I think a big part of that is being clear about what is the optimal dosing schedule, because the approved dosing schedule is going to be different, I think, than what a majority of us recommend ultimately. And I think really that 6 to 8 weeks seems to be the sweet spot in terms of efficacy and minimizing toxicity. So I think that's going to have to be a challenge for us and a task for us as the academic community to make sure that we give clear guidelines there.
Thank you. DREAM7 was not only comparison of two triplet regimens. It was also a comparison between any BCMA and any CD38. And this turns us to frontline treatment, where now any CD38 has a fixed place in transplant-eligible, transplant-non-eligible patients both. And now we saw different trials introducing any BCMA in frontline, green line with Belamaf, and then the Majestic 5 in transplant-eligible patients, up to 5 drug combinations, and in maintenance in Majestic 4. So probably again, you both, a question to you both. What do you think? I keep it very open. What do you think about this?
It's challenge generally, compare drug in newly diagnosed setting. But to me, I want to emphasize one thing. In this DREAM-9 trial of American researchers in Europe, Greek colleague, trying first optimize dose of belantamab, because this is essential. We have to avoid any keratopathy grade 3+. And if it happens, then this drug is very easy to use, and patients can really benefit from this. I would even challenge the maintenance roles, because if you use belantamab, one single dose every 3-4 months, that's really nice for patients.
Yeah, absolutely. Nisha, what do you think?
Yeah, I agree. I think there's an ongoing DREAM-10 study. I think the DREAM-9 results are promising and early. The DREAM-10 study is looking at belantamab versus daralutamide. I think a lot to learn there. In terms of bispecifics in newly diagnosed and maintenance, I think in the newly diagnosed setting, certainly very promising. We see high depths of response with bispecifics. I think the challenge is you have a kind of high bar, in my opinion, comparing it to dara-RVD from the Perseus trial, not only in terms of efficacy, but really safety. And so when we're adding drugs, we want to make sure we're minimizing overlapping toxicities. As Dr. Weisel presented, we're seeing a lot of toxicity early, and you want to make sure you're preserving that patient to get them to transplant, which ultimately I think for a transplant eligible patient is the right approach. So I have a little bit of reservations, I think, thus far, and maybe that will change in terms of dosing, et cetera. I agree about maintenance. I think that potentially could be a really good spot for bispecifics as well as belantamab. But I think, again, dosing needs to be addressed. There's still a good amount of cytopenias, and for someone coming out of transplant to then put them back on something like that can be challenging. And I think not only the frequency, but also duration. Is this something that people need to be on? How long do they need to be on this? So I think a lot of questions still out there, but optimistic and a lot of potential things coming down the pike.
Yeah, thank you. And then we saw combination data. I think we all wanted to see combinations of bispecific antibodies after the first data we saw. And now here, very few patients, 27 with teclistamab, the POM combination. So probably a short view of, again, both of you on those combination.
If I can start, I just want to emphasize one thing, how fascinating this era of the treatment of myeloma is. We are now talking about close to 100% of CR, close to 100% MRD negativity status in newly diagnosed setting. It's really amazing. So there are a lot of challenges, especially toxicity of bispecific is challenge for us, despite we learned a lot, we're using a lot of prophylaxis measurement, but it's still a challenge and toxicity is high. But if it, in the end of the story, will be cured for a really significant proportion of patients, that's matter.
Yeah, I think, I agree with all of that. I think the challenge for me with BCMA and CD38, again, is toxicity. And I think in thinking about combination with bispecifics, I think preclinically what seems to make sense is in combination with IMiDs and CELMoDs. So certainly we want to see more combination data. Everything in myeloma ends up being nothing ends up being monotherapy, for the most part. We know the combinations tend to be better, but I think the anti-CD38 bispecific, it might not be the right choice. And so there's a lot of trial activity looking at IMiDs and CELMoDs, and I'm really excited about those combinations.
So thank you both for this great discussion. In this final section, I will focus on some of the data from this Congress relating to emerging BCMA-targeting agents. We start this session with the abstract 1031, and this is a phase 2 registrational study of anito-capitan, autoleucel, or anito-cel for the treatment of patients with relapsed and refractory myeloma. And anito-cel is again a CAR T-cell treatment, which is again directed against BCMA, however constructed with a so-called D-domain, so a construct which is aiming to reduce toxicity and maintain efficacy. And these were triple-class exposed patients, close to 100, who had received equal or more than 3 prior lines. But you see these patients were heavily pre-treated, nearly half were refractory here in this patient population. And these are the efficacy data of anito-cel with an overall response rate close to 100% after 9.5 median follow-up period, and nearly equal MRD negative remission rate. And PFS rates were also striking with more than 90% after 6 months and close to 80% after 12 months, and a very high overall survival rate, however, with a median follow-up of still early 9.5 months. Looking on the toxicity, it was shown that this unique construct, it seems to really lower toxicity. We had a CRS expected rate of any grade of more than 80%. However, we had very low rates of higher grade and CRS, and we had no delayed or non-ICANS neurotoxicity, and overall a very low rate of ICANS. Also, the hematologic toxicity was low, especially for anemia and thrombocytopenia. So we have here with anito-cel deep and durable responses with a very manageable safety profile. We move on in this section with etentamig or ABBV-383. This is also an anti-BCMA directed bispecific antibody, and here combined with daratumumab dexamethasone in relapsed and refractory disease. And also etentamig aims to lower toxicity and maintains efficacy with a decent construct here for the bispecific. And this is a phase 1b trial, and etentamig was given in various doses, 20 milligram, 40 milligram, and 60 milligram here. And we look overall over 86 patients, which were pre-treated, and the majority also had an anti-CD38 exposure before, and about half were anti-CD38 refractory. And we are looking on the safety profile. The combination of ABBV-383 or etentamig with dara-dex resulted in a hematologic toxicity with a neutropenia of close to half of the patients. There was CRS in 29%, infections in 67%, but these are all grades of infections here. The CRS of higher grade was low with 4% of the patients, and when we look to the overall response rate, we see that the higher doses of etentamig led to a also higher overall response rate with more than 80% in the 40 milligram and 60 milligram dose. We see here a tolerable combination with promising early response rates, and I think we need more follow-up on these patients to see whether this combination leads to an improvement compared to a monotherapy. We move on to another anti-BCMA-directed bispecific. This is linvoseltamab, which was evaluated in the pivotal LINKER-MM1 study, and we saw already data in the previous conventions on this very interesting bispecific antibody. And now we look here on a longer follow-up and selected high-risk subgroup analysis of the LINKER-MM1 study. And here we look on different patient subgroups overall, more than 100 patients treated in the 200 milligram dose of this bispecific, which will be also the approved dose as far as we now know. And we see that patients with a high tumor burden here represented by a high bone marrow infiltration with equal or more than 50% showed a clear efficacy, and pentaclast refractory patients do also show this, and also patients with a high soluble BCMA. However, in all three investigated populations, the overall response rate was a bit lower than in the patients not as refractory or having not that high tumor burden. When we look on the survival outcomes, we see here overall that the median progression-free survival in most analyzed groups is not yet reached. Overall survival rates in the median range from about 2 years to more and not reached. So in regards of safety, there was nothing which was pretty new, so that this analysis demonstrated that linvoseltamab may provide meaningful clinical benefit in high-risk and other hard-to-treat patients, where otherwise we have limited treatment options. I would now like to welcome my co-faculty, Dr. Nisha Joseph and Professor Roman Hájek, to discuss the clinical implications of these presented data. And we start with Imagine-1. Nisha, in the US, you used the CAR T-cell treatments as the first colleagues in the world in a broad and improved spectrum. So you look on a lot of data, and now we see here a novel construct, anito-cel. And do you think, how do you see this data fitting in the current landscape of treating relapsed patients with CAR T-cells?
Yeah, absolutely. I think looking at cilta-cel, one of the benefits of cilta-cel, using it early, is this really impressive remission and this treatment-free period that we saw, almost 3 years for patients. That's very appealing, and we want to use it earlier. I think one of the things that maybe is giving us pause about using it more broadly is the ICANS signal. And particularly these unique neurotoxicities, so things like Bell palsy and Parkinsonism, et cetera. There's also a recent series published about GI toxicity and kind of this profound, almost graft versus host like diarrhea. And I think the challenge around those is not only that they happen at all, is that we have very limited understanding of them. So it limits our ability to treat them effectively too. We have a hard time predicting who's going to get it and how do we manage them. And so I think if you have a patient who you put in remission, but you give them Parkinsonism, and we don't have a good way of how to manage that, that causes some concern. And so I think what's really exciting about the preliminary data, is that we're not seeing those. We're seeing a potentially very effective CAR T-cell therapy that in time perhaps we'll have access to in an earlier line in an ideal setting, and maybe we don't have to worry about those ICANS and those neurotoxicities. So I think still, of course, a lot to learn about the product, but optimistic, so far in terms of the neurotoxicity signal.
And then we move on with the two, even again, novel BCMA-directed bispecific antibodies. So we have two approved with teclistamab and ranatamab in the US and in the EMA countries and also in other countries. And now we look on linvoseltamab and etentamig, the former ABBV-383. So starting with linvoseltamab, we saw here a specific data on high risk, subgroup functional high risk, or patients with high tumor burden. Woman, how was your view on the data? Was that convincing for you, treating those patients with linvo or any BCMA bispec in the future?
I think there is no doubt that there is another very effective anti-BCMA bispecific antibody or engager. So the question is which one we will use. Of course, those who are registered and reimbursed, but then, in the future, we will have maybe 5, 6, the very similar drugs, anti-BCMA targeted. So, it will be a question.
Absolutely. In one of our former sessions, we spoke about combination of bispecific T-cell engagers. Etentamig is a construct where side effects and especially infectious complications should be mitigated due to the low affinity anti-CD3 binding. And this, in theory, makes potential combinations more attractive or easier. Now we saw the data on this phase 1b trial. Probably to you both, what's your view on this combination, on this data? Do you think that optimizing those constructs will make combination easier?
I think I still have some reservations about that certain pairing, but I think that certainly this drug, I can't say etentamig, certainly has potential in combination. There's an ongoing basket study looking at it in different settings, newly diagnosed, et cetera, in combination with IMiDs and other agents. So I'm certain that we will see, increased efficacy and we will find a place where it's well tolerated. I think, as Dr. Hájek noted, the challenge is this space is becoming very crowded, and it's really about which one kind of proves itself first and in what context. The one benefit of ABBV-383 is the monthly dosing, so perhaps that's something that will stand out in terms of in combination. Maybe we'll see less infection and things moving forward because of that, and also certainly the patient experience. So I think I don't have an answer, but I think the trial that needs to be happening are happening, and a lot to learn about when to best use these. But we're going to have a lot of BCMA bispecifics very soon.
Yeah. I agree with Nisha. Definitely future is in combination, and we need some innovative molecule and smart solutions. So this one, ABBV-383, was designed to reduce cytokine release and at the same time to prolong extend half-life that may support once every 4-week dosing. I agree. I'm still not confident that we are there. We saw the number of PRS very limited, below 30%, no grade 3. So maybe there is some very supporting this design of molecule, but we still need more data. Agree.
The comment about CRS is we have started using prophylactic tocilizumab in the US. And so that's really changed kind of our threshold for what's acceptable in terms of CRS. And so really, when I look at side effects, so of course we want to look at CRS and ICANS, what I'm looking at more so is infection and long-term cytopenias. So I think I think that's going to evolve just because if we cut down that CRS rate pretty significantly with giving tocilizumab preemptively.
I agree, Nisha. It's another variable which we have to consider if we evaluating the toxicity. As we moved to to prophylactic use, especially if we want to use it in outpatient clinic. It seems essential, but it's a nice point taken.
Thank you both for this fruitful and inspiring discussion and your deep insights into the data.